Today we have the pleasure of hosting Dr. John Balmes for a talk on air pollution and lung health. Dr. Balmes is a professor of medicine at UCSF and a professor of environmental health sciences in the School of Public Health at UC-Berkeley. He is an attending physician in the UCSF Division of Occupational and Environmental Medicine and the Division of Pulmonary and Critical Care Medicine at San Francisco General Hospital. He was recently named director of the UC-Berkeley UCSF Joint Medical Program. He was appointed physician member of the California Air Resources Board in 2008. Dr. Balmes has been studying the effects of occupational and environmental agents on respiratory and cardiovascular health for 35 years and has published over 200 peer-reviewed articles in the subject matter. Please join me in welcoming Dr. John Balmes.
Can you hear me okay? Well, thank you, Yasmin. It's really a pleasure to be here. I actually graduated from Mount Sinai Medical School in 1976 and did my residency with Maria Padilla. She was my resident when I was an intern, remember it fondly. So it's great to be back. And I started getting into occupational medicine while being here under the tutelage of Dr. Selikoff. So when I got invited to give grand rounds here, it was really a great pleasure, and I couldn't say no. And Allison Lee is a colleague of mine in doing household air pollution work in Africa. I can talk about a lot of different things, but I asked Ellie what I should talk about. She said, John, please talk about household air pollution. So I will. So I guess I make this go forward. Okay, which thing am I supposed to hit? Okay, thanks. So, outline of my talk. I'll define household air pollution for you, talk about the global burden of disease related to household air pollution, talk about early childhood pneumonia, which is the first outcome that I studied related to household air pollution, and move on to adult disease, COPD in particular, talk about some work that I'm currently doing, and then future work. Okay, there we go. So, fire, the taming of fire, is probably one of the first ways we became civilized as humans, and when we learned to cook our food. So we've been exposed to wood smoke and other biomass smoke for a long time. A lot of people are still using solid fuels to cook at home, even though this slide shows that the proportion of people using solid fuels is going down because of population increase. The absolute numbers of individuals around the world using solid fuel, usually in poorly ventilated, not very efficient stoves, is still close to 3 billion. This is a 2010 map of the world showing in red where the greatest concentration of domestic cooking with solid fuels is, and sub-Saharan Africa is the place where most people are exposed to biomass smoke. And Ali studies folks in Ghana and West Africa. I study folks in Malawi and East Africa. So this slide shows, of a Chinese home, shows 3 major solid fuel types. So on the left is wood, center is crop waste, and in the right is coal cylinders. So, since smoke from burning wood or other biomass is something we've been exposed to for a long time, it's natural, doesn't that just change to CO2 and water when burned? Well, that would be true if there was 100% combustion efficiency, but unfortunately, in these domestic cooking scenarios, that's never the case. And it's actually, cooking on wood fire is quite inefficient. It's really a toxic waste factory. Only 20% of the energy generated, the heat energy, goes into the pot to do the cooking. Most of it's waste heat, but there's about 10% products of incomplete combustion, which are fairly nasty. And I'm a lumper rather than a splitter in terms of biomass smoke. Tobacco is a type of biomass. The major difference between burning tobacco and burning other biomass is you don't get the exposure to nicotine in biomass, but there's the same exposure to free radicals, which can cause oxidative stress, particulate matter, carbon monoxide, oxides of nitrogen, and a whole host of toxic organic compounds, including polycyclic aromatic hydrocarbons, which are carcinogenic and capable of causing considerable cytotoxicity. So my colleague Kirk Smith at UC-Berkeley is the first person to have gone out to measure exposures of women cooking with solid fuels. And on the left here is typical industrial hygiene equipment where you can measure by pulling air through a filter how much particulate matter someone is exposed to. So measuring exposure has opened up lots of possibilities in terms of understanding exposure-response relationships, which I will be talking about later. So the exposures that women can get cooking on solid fuels in low and middle income countries is quite high. So on the bottom, you can see typical standards in the US and the developed world, and then you can see the levels of several carcinogens like benzene and formaldehyde are usually much higher in these cooking scenarios. And at the highest exposures, you can get over 3,000 micrograms or 3 milligrams per meter cubed, which is an industrial strength exposure. And if you're cooking like this for many years, you can understand why there may be a lung cancer risk related to exposure to coal and wood smoke. So that's how much exposure there is in general. How much ill health is there? Well, prior to 2010, which was, there was a global burden of disease comparative risk assessment, which I participated in, which I'll share with you. Prior to 2010, we knew from observational epidemiologic studies that pneumonia in kids, not in adults, but in kids, and COPD in women, and lung cancer in women cooking on coal, there was pretty solid evidence. And then the 2000 global burden of disease effort, these were identified as risk related to household air pollution. We added in 2010 lung cancer due to biomass other than coal, blindness from cataracts, and then several adverse birth outcomes. And on the far right, cardiovascular disease, there was evidence about effects on blood pressure and on EKG, no epi, and there still isn't any good epi that really links household air pollution with cardiovascular disease outcomes other than these intermediate outcomes. But I'll talk about it a little bit. It's inferred that because exposure to combustion particles like cigarette smoke and outdoor air pollution cause cardiovascular disease, that biomass smoke particles do as well. We'll talk more about that later. So I participated in the 2010 Global Burden of Disease Comparative Risk Assessment. I cut off the slide after about 50. You can find my name up there. Second line on the right. I actually did a lot of work for this. Did a whole systematic review and meta-analysis with regard to household air pollution and COPD. There's actually a new global burden of disease report that just came out that I didn't participate in, so I'm not going to talk about that. So, in the 2010 comparative risk assessment, household air pollution came out to be the third most important exposure, a risk factor after high blood pressure and tobacco smoke. Now, how could that be? The global burden of disease metric is called disability adjusted life years. I don't know how many of you have heard of that, but it includes deaths as well as disability from various diseases. And you can see here this arrow for acute lower respiratory illness or pneumonia in kids actually accounted for a big percentage of that risk. And that's because young children, when they die, their whole life is lost. So they get a lot of DALYs. We'll be talking about the other colors in that bar as we go along. So I had the great pleasure, after getting a joint faculty appointment at UC-Berkeley, of participating in the first randomized controlled trial of a cook stove intervention to reduce exposure to household air pollution, to try to prevent childhood pneumonia, especially early childhood, in the first 18 months of life. You can see in this photo, these are women in the Western Highlands of Guatemala. These are Mayan women. They pretty much live like they've always lived, except they now all have cell phones. But they cook over open fires, 3-stone fire, and baby is strapped on mom's back until the baby can walk, roughly 15 to 18 months. We did this randomized controlled trial of a stove on the right called a plancha. It's quite an improved stove for multiple reasons. It doesn't actually burn the wood any cleaner, but the smoke goes up the chimney, so it goes outside at least. It cost about $187 when we did the study in 2003, 2004, which was way more than these folks could afford. They liked it ergonomically. The woman doesn't have to bend over. There's less risk of the kids getting burned. You can put food on top of there, and the food is not directly on the ground, because in these homes, the chickens go right in through the door, dirt floors. So we spent some time determining that this stove was acceptable. Matter of fact, it was, the participants were pleased to get it. So the trial was control on the left versus intervention on the right for 18 months. We followed the kids, or the families, weekly to see if there was any evidence of pneumonia. If there was, the kids were evaluated by a study physician. We tried to get x-rays to document whether pneumonia was present or not. And after 18 months, the control group got the stove. So we did, in fact, reduce exposure. The children with the chimney stove had about half the exposure as the children with the open fire. But you can see there's quite a bit of overlap. So it was not a clean break between the two study groups. And those of you who might know about air pollution levels, these are levels in the, these are the personal exposures of the kids. And we use carbon monoxide as a proxy for particulate matter, because you can measure carbon monoxide on kids with tubes. And then we developed a correlation between the carbon monoxide and PM. So we got a 50% reduction in exposure on average, but the chimney did not protect all children. Now why? And I was trying to say that these levels are sort of off the scale. Beijing is like 180 micrograms per meter cubed on a sort of typical bad day. Delhi might be 200 micrograms per meter cubed. So basically, when cooking is occurring inside these homes in the Western Highlands of Guatemala, it's basically Beijing or Delhi level exposure. So we just brought the exposure from horrible to bad. And this is why we didn't reduce the exposure more. We actually achieved an order of magnitude reduction in the kitchens, but you can see the smoke just comes out the chimney and goes back in these not very well sealed homes. And we actually had no significant difference between the control houses and the intervention houses in terms of the bedroom level. I will say the bedroom was not often a separate room either. So we did, in fact, even with this crude exposure reduction from horrible to bad, achieve a statistically significant benefit in terms of severe pneumonia. And that was whether we assessed it with field worker symptom-based, physician diagnosis, and we did manage to get respiratory syncytial virus antibodies on the kids, and it was only in the RSV negative pneumonia that we had a significant effect, suggesting that it was bacterial pneumonia rather than viral pneumonia. And this was all with the severe pneumonia outcome, which was defined as a saturation less than 87%. So that was the intention to treat analysis, control versus intervention. But what's actually more interesting for policy purposes is the exposure-response relationship. And these circles are deciles of exposure from highest on the right to lowest on the left. And we did achieve a reduction of exposure, about 50%. But this is where we want to be. If we could get all these folks to cook on cleaner stoves, we could achieve a remarkable reduction in childhood pneumonia. And even the 50% reduction that we got is as good as a pneumococcal vaccine effort. So this is important. We were trying to get the Ministry of Health in Guatemala to understand that if they supported a stove intervention program, they could improve the quality of life for these Mayan peasants, but also improve the health of certainly the kids, but I'm going to tell you about the mothers as well. So what the first case of adult lung disease related to wood smoke exposure was a patient of mine at San Francisco General Hospital. I was asked just to fill in as an attending during a bronchoscopy, and we did this bronchoscopy, and I saw this black stuff, and I turned to my fellow and said, "This guy smokes crack," because that's the usual reason for black airways like this. But the patient swore up and down that he didn't smoke crack, and when we were able to get a better history, it turned out that he had made charcoal with his family for about 15 years in Mexico before moving to San Francisco. So you can get impressive disease from chronic wood smoke exposure. And actually COPD is the most common outcome. Just to go back, this gentleman actually had interstitial lung disease, so-called hot lung, from his heavy exposure being a charcoal manufacturing person for 15 years. But what's more typical is COPD. And I just remind you, this is the global initiative for obstructive lung disease definition of COPD, and it doesn't say cigarette smoke. It says exposure to noxious particles or gases, which also is what biosmoke involves, biomass smoke. So in the developed world, tobacco is the primary cause of COPD. In Mexico and other low and middle income countries, among men, tobacco is still the main cause of COPD, but among women in low and middle income countries, it's usually biomass smoke, because at least in the two countries where I've worked, Guatemala and Malawi, the women don't smoke. So worldwide, it's a huge cause of COPD, household air pollution from domestic cooking. And so the reason I was one of those 100 authors of the Global Burden of Disease Comparative Risk Assessment in 2010 was that I did a meta-analysis with a Stanford medical student of the literature up into 2010 about COPD and biomass smoke. It was all observational epi, no randomized controlled trials. And there were over 20 papers. Here's the forest plot. And overall, there was a pooled effect estimate of an odds ratio of about 2.7, very statistically significant. For men, it was below 2, it was like 1.9. And with the men, it wasn't entirely clear that it wasn't confounded by smoking. But with women, we were pretty sure that it wasn't. So there's the piece of the household air pollution component that's due to COPD, smaller than what's due to childhood pneumonia, because women are older, they lose less disability adjusted life years. So with the platform of the randomized controlled trial in Guatemala, we were able to study adult outcomes as well. And so we did see a difference in personal exposure of the mothers. Again, we had an order of magnitude reduction of exposure in the kitchen, but with the mothers wearing personal CO monitors, there was about a 30% reduction in the intervention homes. And there was about a 30% reduction in eye irritation from the smoke. Made sense. And we actually had a nice exposure-response relationship for personal CO and respiratory symptoms. The more exposure, the more cough and wheeze. So then we went on to measure lung function. And this was published in Environmental Health Perspectives last year. The intention to treat analysis showed no effect of decline in lung function between the control homes and intervention. Actually, it was a bit confounded by a learning effect. The women actually got better as a whole with practice. It's a problem doing repeated lung function. But when we did an exposure response analysis between exhaled CO, with the adult women we had both personal CO and exhaled CO. We actually had the exposure response with both, but it was stronger for exhaled CO. And these women don't smoke cigarettes, so this is all from their biomass, and they don't drive diesel trucks or anything. It's all from the biomass smoke. We did have a nice relationship. This turned out to be about a 30 milliliter enhanced accelerated loss of lung function compared to women with low exposure to CO. And there was a study in Mexico. They actually borrowed our study design. It's the same childhood pneumonia study. They also used a stove similar to our plancha called a patsari. Their intention to treat analysis also found no effect. And that's because adherence with the patsari was poor. It wasn't that like the women didn't like to cook on the patsari, but they also would, it's called stacking. They'd also use the traditional fire for certain foods, especially cooking animal feed. But in the women who reported using the stove exclusively, there was a lower decline in FEV1 compared to open fire use, and it was about the same magnitude as what we found. And actually, the study was not that far away in Mexico from where we were doing our study in northern Guatemala, same type of folks. So these two sort of experimental design studies found an effect of an improved stove in trying to slow the decline in lung function. We went on to get some induced sputum from some of the mothers in our Respire study. And when we just did an intention to treat analysis, chimney stove versus the open fire, it's only MMP9, matrix metalloproteinase 9, where there was a significant effect. But when we did, again, an exposure response with either exhaled CO or personal CO, we had more impressive effects. This time, with the exposure response, we had an effect in terms of MMP9, TNF-alpha, IL-8. I will say that this was a tour de force that one of my fellows did. She brought down all the equipment to do induced sputum, and this is up in the mountains in the middle of nowhere. Very impressive effort on her part. So we had a follow-up study to Respire called Respire to grow. We followed the kids that had been in that initial 18-month of life Respire study. We were able to follow them when they were old enough to do spirometry about between age 5 and 6. Oh, excuse me, these are the adult women, sorry. So that study was for the kids. That's the next slide. We weren't really funded to study the adult women, but I snuck in one cross-sectional repeat spirometry. So we had 540 people in the original Respire study. By the time we came back about 6 years later, we were able to find 306 of those 540 women. We got good spirometry at 265 of them. And so there were really no differences in any of the measured spirometric variables during the study period after adjustment for confounding. This is, again, an intention to treat analysis. Open fire versus the plancha stove. But that doesn't really surprise me because the only differential exposure was the 18 months period of when the intervention group got the chimney stove. And then after 18 months of the trial, the control group got the chimney stove. And we weren't able to do exposure monitoring of the adult women. So this just got published this month in Chest. It was a little bit disappointing, but I was pleased to see that a negative study got published because it's a cautionary tale for folks who are doing this work. Now we also, we were actually funded by NIH to study lung function in the kids that had been in the Respire trial when they got to be over age 5. And those of you who have any knowledge about doing lung function in young kids, it's hard enough to do, period. Again, in the Western Highlands of Guatemala, it's really hard, but we had an incredible study physician who was able to get good spirometry. I won't try to explain to you group 3, it's too complicated, but group 1 was the control group, was the intervention group in Respire. Group 2 was the control group. Again, the differential exposure period was only 18 months, then everybody got the improved stove. But even so, we had a statistically significant effect in peak expiratory flow on the right, and if you look at FEV1, we came pretty close to statistically significant. And this, again, is just with 18 months of differential exposure, but here, as opposed to the adults, it's 18 months at the start of life when the lungs are still growing. So I want to move on to cardiovascular disease. This is the most controversial piece of the global burden of disease comparative risk assessment, because for pneumonia in kids and COP in adults, we have good epi data. With CVD, cardiovascular disease, we're inferring the results, and I'll show you what. This is called an integrated exposure response curve, and down at the bottom, with low particulate matter exposure, bottom left is outdoor air pollution. And then the stars are secondhand tobacco smoke. And then up to the left you have active smoking. And though we don't have any epi to support this, the solid fuel zone biomass smoke exposure lies right here in terms of how much combustion particles one is exposed to. And because we had some intermediate endpoints, blood pressure, and some SD segment changes related to biomass smoke exposure, we were able to convince the Global Burden of Disease Executive Committee that they should count cardiovascular disease. So that's part of the reason household air pollution made it to the third most important risk factor. And there aren't really data to support this. This is inferred. But the whole point of the Global Burden of Disease comparative risk assessment is to try to figure out which are the factors that we should pay the most attention to, public health-wise. So, data gaps. We really need to know how clean stoves have to be to prevent early childhood pneumonia, COPD, lung cancer, and CPD. We need epidemiologic and toxicological evidence to support the inference that biomass smoke can increase risk of cardiovascular disease. And we need better understanding of barriers to adoption of clean stoves. And I'll show you such a stove where there may be some barriers in a minute. The plancha stove we use in Guatemala, we spent several years, my colleagues spent several years figuring out what would fly, and that plancha stove was, again, welcomed. But that's not always the case with stove intervention trials. And research in this area would be helped by biomarkers of exposure and early effects. I really wish we had something like cotinine for wood smoke, because even when we do personal exposure monitoring, we're only getting a snapshot of the 24 or 48 hours that we have such a monitor on someone, and it's not a really good marker of chronic exposure. So some research needs. I think we need better randomized controlled trials of clean stoves, longer duration for lung function effect. The two published studies that I showed you, ours was for 18 months and the Mexican study was for 12 months. It's really not long enough to see if there's an effect on accelerated decline of lung function. We need other preclinical outcomes. There's the one study of ours with induced sputum, but that's not very practical for large-scale epi studies in low and middle income countries. We definitely need exposure response data, so that we really need that to define how clean a stove has to be. We need to understand mechanisms. We presume that the mechanisms are similar to tobacco smoke, and I think they probably are, but we really don't know that. So there's room for basic science. And then I've already mentioned biomarkers, both of exposure and susceptibility. So there's a current opportunity. The Global Alliance for Clean Cook Stoves it's part of it's part of the United Nations Foundation. It has a goal of enabling 100 million clean cook stoves to be distributed around the world by 2020. And I said distributed on purpose. They're not actually supposed to be given away. We're supposed to be creating markets for these stoves that are more sustainable. Giving away interventions in low and middle income countries usually doesn't lead to sustainable adoption. And again, we need to know how clean these stoves need to be. And I want to give a plug to your former senator, because she started this Global Alliance for Clean Cook Stoves. My colleague Kirk Smith, who started this study in Guatemala, had an opportunity to meet with her when she was Secretary of State, and he convinced her that she should put energy into trying to reduce household air pollution, because she was, as you remember, very much into children's and women's health. So future directions in terms of my own work. So in Malawi, I'm funded along with colleagues at Liverpool School of Tropical Medicine to conduct a randomized controlled trial of an advanced stove to prevent childhood pneumonia. We only had 540 kids in our study in Guatemala. This is the clean cook stove. It's called a Phillips stove. It has an electric fan, so it's just like blowing on a campfire. That electric fan allows the wood to burn cleaner. It doesn't work everywhere. I'm not even sure it's working in Malawi. We'll talk about that. This is showing some kind of flatbread, sort of like a tortilla, but we tried the Phillips stove in Guatemala, and our Mayan women really couldn't make good tortillas on the Phillips stove. So in Guatemala, I'm funded to conduct a pilot study to test efficacy of several clean stoves, including liquid propane gas, which is clean, but distribution of gas cylinders to Mayan villages in the western highlands of Guatemala is not easy. And also, it's not clear that women like to cook tortillas on this either. So, in Malawi, how many of you actually knew where Malawi was before I showed you this? Few. It's in sub-Saharan Africa. Sub-Saharan Africa is the poorest part of the world. Malawi is often called the poorest country in sub-Saharan Africa. And we have two study sites, Karonga in the north and Chikwawa in the south. Chikwawa is the poorest part of Malawi, so it's one of the poorest places in the world. I thought when I worked in Mayan villages in Guatemala that I'd seen poor, but then I went to Malawi. Now I've really seen poor. Blantyre is the old British capital. It was Nyasaland, I think, before it was Malawi. It's actually kind of a nice place to do research. My Spanish is very limited, so Guatemala it's always problematic. I tend to fall into French when I'm trying to speak Spanish. In Malawi, it was a British colony, so English, educated people speak English. They're very proud of the fact that they're not Kenya, meaning they don't fight. Even though they're two different languages in north-south, they've had peaceful transfer of government since 1994. So aside from the fact that it's a long way to go, and it's hotter than hell, it's a pretty good place to do this kind of research. So the CAP study, our cooking pneumonia study, it's a large-scale version of what we did in Guatemala. That's actually why I'm a co-investigator, because I helped them, my Liverpool colleagues, do a similar kind of protocol. It's a village cluster randomized trial of this Philips stove. Instead of the first 18 months, we're actually looking at 0 to 5 years of age. It's a 2-year trial. And this is an old slide. We've actually recruited 7,200 households. We have 9,000 kids. And we're measuring carbon monoxide. Instead of with passive tubes, we have this LASCAR device. And in addition, in 400 homes, 200 in control and 200 in intervention, we're doing stove use monitoring, that's what SUMS is, and actual particulate matter level measures. So how do we get the electricity to power this stove? Cheap $10 solar panels from China. And here's the stove in action. We give 2 stoves to each family, because these are subsistence farmers. In both Guatemala and Malawi, it was corn. It's a subsistence crop. In Guatemala they make tortillas. In Malawi they make sima, which is a corn porridge. One stove is for the porridge to cook, and the other stove is for the sauce, which, if they're lucky, will have some protein in it. This is not a sustainable intervention. So this is not an effectiveness trial. This is an efficacy trial, because these stoves break down. The cheap solar panels don't always work. We have a robust system of trying to maintain the stoves, but we still get stacking where only one of the stoves is working, so women cook on open fires. So it's not a long-term solution, but we're hoping to show that, again, that reducing exposure will have a significant effect on childhood pneumonia. So I actually don't get paid to be part of CAPS, even though I'm a co-investigator, helped write the grant. It comes from UK funding, and it was too complicated to pay me. So I got paid in kind, which is to be able to start an adult lung health study. There's a Burden of Obstructive Lung Disease consortium that's done studies of prevalence of COPD around the world. And we signed up to have to be a bold site in Chihuahua. That's the poorest part of Malawi, also the hottest part. And we're doing a randomized recruitment of 2,000 adults, trying to get both men and women, and both sort of young to middle-aged and then older. And this is a population-based study, not an intervention trial, but nested in our population, we do have 3,600 households participating in CAP. So we will be able to do a nested intention to treat trial in here. We're funded to follow from both, we're funded by both UK and NIH to follow folks for 2 years. I'm trying to get NIH funding to go beyond 2 years. Hasn't been easy. And we're doing annual exposure assessment with this device that measures both carbon monoxide and particulate matter. It's a backpack, and believe it or not, I've been able to get over 1,200 people to wear this for 48 hours at a time, and we're just starting our annual It's a drag to wear a backpack for 48 hours. This is study subject number 1 in Chihuahua Village. You can see 4 of her 7 kids hovered around her. We actually had more field workers, since it's the first subject, more field workers than family. I'm off taking the picture here. But again, doing lung function in the field is challenging, but we've gotten actually very good results so far. So I just want to acknowledge my colleagues at UCSF, 2 pulmonary fellows that have worked with me, Janet Diaz and Michael Guarneri. The UC-Berkeley household air pollution team. Kirk Smith is a member of the National Academy of Sciences for his work with regard to household air pollution. He's the first guy to ever measure the exposure. Colleagues in Guatemala, colleagues in Liverpool, some of the adult lung function work in Respire in Guatemala was funded from the Norwegian Research Council. John McCracken was getting his doctorate at Harvard. He actually married Anaite Diaz in Guatemala, who was our study coordinator, and he's now my collaborator in Guatemala. And then I've mentioned my current collaborators in Malawi, Kevin Mortimer and Stephen Gordon from Liverpool School of Tropical Medicine. And shout out to 2 of our Guatemalan field workers up in the top. And then, despite the fact that it's hotter than hell in Malawi, these are some of our field workers dressed in ties and shirt after they've unloaded a bunch of our Philips stoves from a container. So thank you.
Questions?
Yeah, you showed one picture you showed of a home in Guatemala had a zinc roof on it, which suggests to me that they may get their water from roof rainwater harvested. How do they sterilize? Do they take their water from the roof if they do it, and to make it potable, do they heat that on? Do they chlorinate it, or do they sterilize it? Or they don't do any either.
They do boil water for cooking purposes, but they not for drinking purposes. So I never drink the water when I'm in Guatemala, and I don't eat fresh vegetables when I'm in Guatemala. So I actually, diarrhea is an issue.
So is there any way to leapfrog over the issue of boiling water, which is a component of the household air pollution, by chlorinating it, for example, which other countries do?
So in Guatemala, I'm not aware of sort of a holistic approach to environmental health, but there was a study that the CDC funded in Kenya where, in addition to improved cook stoves, they also were putting in latrines and doing some kind of water disinfection. I don't know if it was solar, that's one way to do it, or chlorination. It would have been chlorination with pills. And that, to me, that holistic approach makes a lot of sense. I used to always feel bad in Guatemala, and now I feel bad in Malawi. I'm giving improved ways to cook, but they don't have enough to eat. So malnutrition is a bigger problem to me than household air pollution. So a holistic approach to health is, to me, a better way to approach improving the lives of these folks. So it's a good point.
John?
So it looks like most of your studies have involved a pretty significant change in behavior, which is often one of the most challenging things in global health. You're getting people who are using traditional stoves for hundreds of years as part of their culture to use these new technological devices. And so I'm curious what sort of advanced work you have to do to get health education and so forth to get people to adopt these new.
It's a very good and important question. So in Guatemala, my colleague Kirk Smith worked for several years to try to figure out where he should do the study and to come up with a stove that was acceptable. And like I said, that stove is actually welcomed, that plancha. It's considered a major wealth asset. And so we didn't have a problem there because we did a lot of advanced field work. In Malawi, we did enough, my colleagues at Liverpool School of Tropical Medicine did enough advanced work that they knew that people would accept them into their homes. And that we knew we needed 2 to cook both the porridge, the corn porridge, and the sauce for it. But we didn't do enough advanced work to see how the long-term sustainability would be. And I go back to Malawi. I'm going Thanksgiving week. Each time I've gone back, I've been more disappointed because there's been decreased use of the stove exclusively. The participants are still enthusiastic about the study, but the women tell me that the stove is broken half the time, or that it's not charging properly with the solar panel. So yeah, we need a lot of work in terms of studying behavior with regard to adopting new cooking technologies. And there's a doctoral student from the Liverpool School of Tropical Medicine who's actually doing that now.
Maria?
John, thank you so very much for your work, and thank you for sharing it with us. It was just wonderful to see that.
It's great to see you again.
I was thinking about the women where you only saw that 31%, the 31 cc changes. Was there any difference? As the younger the women, do they have a better response rate to the intervention? Or was it something that you couldn't see? That's one question. The other question is, you showed us a slide that looked almost like hypersensitivity pneumonitis with a little bit of a granuloma formation in one thing.
A lot of carbonaceous material.
Yeah, and so the question is, how much interstitial lung disease is there that is happening at the same time, and perhaps obscuring your information, because we know that the spirometry and the combined obstructive lung disease and fibrotic lung disease is very well maintained.
So you're still as sharp as ever. So I'll start with the second part. There's actually the BOLD consortium that I mentioned that we're part of now in Malawi. Peter Burney, distinguished pulmonary epidemiologist, head of that consortium, just published, I guess in 2014, cross-sectional data, because that's all BOLD normally has, from around the world. And there seemed to be an association with a restrictive impairment and biomass smoke in these BOLD studies around the world. And so that brings up the issue of interstitial disease. We know interstitial disease occurs with chronic biomass smoke exposure. It's called hut lung. I showed you one case. Nobody's done chest CT imaging of a large population of these folks. So we don't know that, but I think your point is well taken. Also, TB is an issue in many of these places, which also causes restrictive impairment, as you know. And it's likely that biomass smoke exposure actually enhances risk of TB, just like tobacco smoke does. It's not been shown as clearly. I have colleagues trying to do that's such a study in Nepal right now. And your first question was about, there's a difference in terms of age. We only had, I think about, in the initial study, we had 500 women. In the follow-up, about half of that. We looked at age both times, and there didn't clearly seem to be an age effect. But part of the problem was there were a lot of young women who may still have been growing, too, in terms of their lung function.
Hi, thank you for the talk. So if it's very difficult to get these women to change their cooking habits or to use these stoves, has anybody just studied giving people face masks to wear?
Nobody has studied that. There's a big push to try to get cleaner stoves that we don't even have to worry about. Like there's no reason why women in low and middle income countries, if we had the resources, couldn't cook on electricity or natural gas. It's just going to take a long time before electricity or natural gas is going to come to Chihuahua or the Western Highlands of Guatemala. So we have to make do with other types of stoves, and nobody has really come up with a perfect stove. Ali in Ghana does have a LPG arm to the childhood pneumonia study there. We couldn't pull that off in Malawi, though we're thinking about whether we can try to do it. But it's really a problem. Trying to affect behavior change. Just like trying to get people to stop smoking or to diet, it's hard to get people to change their cooking habits, especially if foods are perceived to taste better using a traditional open fire.
Two questions. Could you just comment on the efficiency of natural gas and propane, and also
They're similar.
And how high are they? How good are they?
Well, natural gas isn't as good as electricity. There is some oxides of nitrogen. There's very little particulate. It burns pretty clean. The particulate you get exposed to from cooking is actually from the food that you're cooking, especially if you're frying. So natural gas and LPG are clean.
And
In terms of particulate, there's oxides of nitrogen and carbon monoxide.
so I was going to say the particulate exposure with regard to cardiovascular disease you'd expect to be enormous here. Do you see a signal at all, or is it?
Well, very few people have looked in a cardiovascular disease outcome. We sort of need a Framingham study for low and middle income countries with regard to biomass smoke. Blood pressure has been looked at both in Guatemala and China. There's a blood pressure effect. John McCracken, my colleague in Guatemala, showed as a doctoral student that after when the control group in the Respire trial went from open fires to the plancha, the blood pressure went down in the grandmothers in homes. He also had an EKG effect in terms of ST segment. There was actually there was less ST segment depression in these grandmothers. And in China, we have seen blood pressure go down with chimney stove intervention. But nobody, to my knowledge, has really done a proper epi study of cardiovascular outcomes other than these sort of preclinical outcomes.
One last question in the back.
So, hi, John.
Hey, Neil. Another mentor of mine, but not here, at Yale.
In many of these epidemiologic studies, occupational, environmental, underlying airway hyperreactivity is a risk factor for the progression of some of these chronic obstructive pulmonary diseases. Do we have any information about the prevalence of asthma or allergic type diseases in these populations?
So I was asked to get involved with the Guatemala work by Kirk Smith because he had this notion that we see asthma in relation to the exposure. I told him I didn't think so because of the rural-urban gradient in terms of asthma. I mean, I said the chickens literally go right into the living area, dirt floors, and we looked hard for asthma. We had a physician, a study physician, and we basically didn't find any asthma in our kids. We didn't really look in the adults the same way. We just did lung function and respiratory symptoms. We didn't actually, but with the kids we looked for asthma and didn't find any, basically.
Thank you very much.